Learning Gonioscopy, a trainee ophthalmologist guide. I have no financial disclosure. We do two types of gonioscopy, direct and indirect. The direct being done intraoperatively and the indirect gonioscopy we do at the slit lamp. We have to identify whether the angle is open or it is closed. We do that using the corneal wedge technique where a thin slit of beam is projected, the tip of which indicates the level of the Schwall base line, following which we identify the normal angle structures from the Schwall base line up to the ciliary body band. Comparing open versus closed angle. If the angle is closed, in OPD we can do manipulative gonioscopy to differentiate. If on manipulation the angle gets opened, it is called a positional closure. As opposed to when the angle does not open on manipulation, it is a type of synechial closure. In synechial closure, we see goniosynechiae. In open angle glaucoma, we commonly encounter primary open angle glaucoma, where we see all the structures from iris root to Schwall base line. Angle pigmentation may be seen, variable with age. Sometimes even iris processes may be visible. In cases of juvenile open angle glaucoma, we see an open angle and along with that we may see prominent iris processes. Primary angle closure glaucoma, we see that the angle structures are not visible, that is, the angle is closed. Along with that, in chronic cases, we may see goniosynechiae with blotchy pigments at or anterior to the Schwall base line. In neovascular glaucoma, we see the vessels arborizing on the trabecular meshwork in an irregular manner, along with early pars formation in the angle. In advanced cases, we see that there is complete pars formation in NVG. In ICE syndrome, we see essential iris atrophy and iridocorneal adhesions. Coogan-Rees variant showing the nodular pigment and iridocorneal adhesions. In cases of developmental glaucoma, Axenfeld-Rieger syndrome where we see peripheral large iridocorneal adhesions, iris stromal thinning and holes. Here we are seeing the posterior embryatoxon, which is the anteriorly displaced Schwall base line seen in cases of Axenfeld-Rieger. In children with primary congenital glaucoma, we see flat iris insertion and a poorly developed trabecular meshwork. Swan-Jacob showing the high iris insertion and iris processes. In aniridia, we see congenital hypoplasia of iris and a rudimentary iris stump along with ciliary processes. Secondary glaucoma, where we see patients with pigment dispersion syndrome where there is liberation of pigments from the iris which get deposited anterior to the Schwall base line. Here we can see the Sampulesi line and the concave iris appearance. Pseudoexfoliation syndrome where we can see white powdery deposits at the angle. In angle recession, we see irregular widening of the ciliary body band. Post-traumatic iridodylisis with ciliary processes visible. In uveitis, we can see either an open angle glaucoma or a closed angle glaucoma with variable presentation having broad base synechiae, and sometimes we can even see pigment clumps getting accumulated. Post-cataract surgery, we can have the PCOL haptic getting rubbed and liberating pigments, causing uveitis and glaucoma, ACIOL with iris bombay formation. Post-vitreoretina surgery, hyperoleon, causing secondary glaucoma. Post-trabeculectomy, we can visualize the ostium whether it is patent or it is getting blocked with iris tissue. We have come across foreign body in the angle. Here we can see wooden foreign body post-penetrating injury. Here is a patient who had a glass piece in the angle post-trauma. In the same setting, we can also use the gonioscope to visualize the optic disc. Thank you.